Welcome to Board Pearls. This is episode 1 of 4 of the biliary tract disease chapter in the pancreatic and biliary disease module. This episode is gallstone disease and acute cholecystitis, the stone types and what each one tells you about the biochemistry that made it when symptomatic stones send a patient to cholecystectomy, how acute cholecystitis is graded and timed, and the acalculous and emphysematous variants that change the host risk and the urgency. Stones are the entry point because they explain almost everything else the gallbladder does to a patient, since the phenotype of the stone tells you what biochemical environment produced it, and that environment is really the risk factor list seen from the mechanism side. 3 phenotypes, 3 environments. Cholesterol stones are the dominant Western stone, about 3/4 of the total, yellow-brown, crystalline, and usually lucent on plain film, and they form when bile turns lithogenic, which happens through any combination of 3 pathways. The first is cholesterol supersaturation, where raised cholesterol, lowered bile salts, or lowered phospholipids tip the solubility math so cholesterol falls out of solution. The second is gallbladder dysmotility, where stasis prolongs the contact between supersaturated bile and the mucosa, and the longer that contact, the more cholesterol nucleates. And the third is the nucleus itself, where mucin, bacteria, ceftriaxone calcium crystals, or various proteins seed crystalline cholesterol into a stone. Almost every gallstone risk factor lines up with one of those 3. Estrogen, parity, and hormonal therapy raise hepatic cholesterol secretion and drive supersaturation. Progesterone slows the gallbladder by relaxing its smooth muscle, which is dysmotility, and obesity, hyperlipidemia, diabetes, and certain ancestries raise supersaturation through inherited or acquired cholesterol traits. Rapid weight loss from bariatric surgery, very low-calorie diets, or TPN, removes the postprandial gallbladder stimulus and creates stasis. Vagotomy and diabetic autonomic neuropathy abolish vagal contraction, and octreotide inhibits contractility directly. Ileal disease and resection interrupt the enterohepatic circulation and shrink the bile salt pool, removing the solvent for biliary cholesterol, and the phospholipid transporter mutations keep phospholipid out of bile so it can't solubilize cholesterol. The classic mnemonic of female, 40, fertile, fat, and fair captures the demographics, but ethnicity layers on top, with some Native American populations approaching a 50 to 60% adult prevalence. So pregnancy in a woman of indigenous or South American ancestry stacks hormonal supersaturation onto inherited supersaturation, and that's the high-yield vignette. Black pigment stones are a different chemistry. Calcium bilirubinate and calcium phosphate, hard, and often opaque on plain film, and they form when unconjugated bilirubin delivery to the gallbladder exceeds solubilizing capacity, which happens in chronic hemolysis, so think sickle cell disease, hereditary spherocytosis, thalassemia, and mechanical valves or assist devices with shear hemolysis, and in Gilbert syndrome where the conjugating enzyme is deficient, and in cirrhosis and cystic fibrosis and Crohn's disease. So if the stem hands you a mechanical valve or a sickle cell patient with stones, the phenotype is black pigment, and the mechanism is excess unconjugated bilirubin. Brown pigment stones are the third and the easiest to miss, soft, greasy, completely lucent, made of unconjugated bilirubin, mucin, cholesterol, and fatty acids, and they don't form in the gallbladder. They form new in the bile duct itself under stasis plus bacterial infection, because bacterial enzymes deconjugate bilirubin in the duct, and the unconjugated bilirubin precipitates with calcium. That explains a counterintuitive observation. Brown pigment stones are the most common stone appearing more than 2 years after cholecystectomy, because by then any retained gallbladder stone has declared itself, and what you're seeing is fresh ductal genesis, which is why they associate with biliary stricture, duodenal diverticulum, post-sphincterotomy anatomy, and biliary parasites. Time since cholecystectomy is the pivot. Within 2 years, suspect a retained stone. Beyond 2 years, suspect a brown pigment de novo stone and start looking for the stasis driver. And one factor sits outside the 3 pathways, ceftriaxone, which precipitates as calcium ceftriaxone crystals and seeds stones directly, so a single course can produce stones in a previously stone-free patient, and the vignette is a child or adult who developed sludge or stones during or shortly after a ceftriaxone course. Now the clinical question. The patient has stones. What do you do? About 10% of adults have stones, and 3/4 of those are asymptomatic. And the observation versus surgery math is straightforward, because asymptomatic stones progress to symptomatic disease at only 1 to 4% per year. while elective cholecystectomy carries a small but real perioperative mortality, so the progression rate doesn't exceed the operative risk, and the answer is observation. Once the patient becomes symptomatic, the math flips, because although about a third stay asymptomatic after a first colic episode, the rest face a meaningful yearly risk of severe complications, which tilts towards surgery in any fit patient. Biliary colic is the only symptom clearly attributable to stones, a severe epigastric or right upper quadrant pain lasting 30 minutes to several hours, often radiating to the right shoulder or scapula, frequently after fatty meals because the gallbladder contracts against an obstructing stone, and often nocturnal, with pain-free intervals of days to months, and that intermittent severe pain with full resolution between attacks is the recognition pattern that triggers cholecystectomy referral. What biliary colic is not is dyspepsia, because bloating, fullness, belching, and vague upper abdominal discomfort occur at identical rates in patients with and without stones, so dyspepsia is not attributable to stones, and the historical relief of dyspepsia after cholecystectomy is largely a placebo effect, meaning a patient with stones and dyspepsia but no true colic probably has functional dyspepsia or irritable bowel, and cholecystectomy won't help, a point we'll return to next episode under functional gallbladder disorder, because overutilizing cholecystectomy for vague upper abdominal. There's a small high-yield list of asymptomatic situations where prophylactic cholecystectomy is still offered, and the organizing principle is that a cancer or surgical emergency risk has shifted the calculus far enough to operate before symptoms arrive. A porcelain gallbladder with patchy or incomplete calcification gets surgery, because the non-calcified mucosa can still harbor progressing dysplasia, whereas a completely calcified burnt-out wall carries lower cancer risk and can be observed in selected patients. Stones 3 centimeters or larger carry roughly 10 times the gallbladder cancer risk of small stones, because chronic mechanical irritation drives metaplasia to dysplasia to carcinoma over decades. Polyps coexisting with stones combine 2 cancer risk channels and warrant cholecystectomy. Native American women with stones carry a high enough baseline cancer risk to justify prophylactic surgery. A pancreaticobiliary maljunction with biliary cysts warrants cholecystectomy as part of cyst excision, because the gallbladder bears the brunt of the refluxate. And chronic salmonella carriage, sickle cell with documented stones, and transplant evaluation are all listed indications, with bariatric candidates who have known stones often operated concurrently because the rapid postoperative weight loss precipitates symptomatic disease. The vignette is a Native American or Mexican American woman with stones plus one of these modifiers, and the answer is cholecystectomy, even though she's asymptomatic. Now the disease itself. When cystic duct obstruction stops being intermittent and becomes persistent, colic becomes acute cholecystitis, and the mechanism is mechanical first and inflammatory second. Bile concentrates behind the obstructing stone. The mucosa liberates an irritant lipid from membrane phospholipid. The wall mounts a chemical inflammation, and bacterial superinfection completes it, so the pain becomes constant rather than colicky, and you get fever, leukocytosis, and a positive Murphy sign. One pearl on the liver tests. In uncomplicated cholecystitis, the liver chemistries are normal or only modestly raised, generally under twice normal, so a marked transaminase or bilirubin elevation in what looks like cholecystitis is your signal to widen a differential to either concurrent duct stones or Morizi syndrome, where an impacted cystic duct stone compresses the common hepatic duct, both covered in the next episodes, but the pattern starts here. A big bilirubin in a cholecystitis vignette means look at the duct. The Tokyo guidelines establish the diagnosis by requiring agreement across 3 things, because each alone is nonspecific: local signs like a Murphy sign, a right upper quadrant mass, and tenderness; systemic signs like fever, leukocytosis, and a raised CRP, and confirmatory imaging. Right upper quadrant pain, leukocytosis, and gallbladder wall findings each have long differentials, so it takes all 3 agreeing to make the diagnosis. Imaging starts with a right upper quadrant ultrasound, where a sonographic Murphy sign, meaning the probe compresses the gallbladder and reproduces the pain, plus wall thickening greater than 3.5 millimeters, pericholecystic fluid or edema, and distension over 4 centimeters transverse, all support it. When ultrasound is equivocal or you suspect acalculous disease, the nuclear HIDA scan is second line, and its mechanism is what makes it definitive rather than merely consistent. If the tracer fills the bile duct and the small bowel, but cannot enter the gallbladder, the cystic duct is obstructed by definition, which is radiographic proof of the disease. Once you have the diagnosis, how aggressively to operate is set by the Tokyo grade, and the logic is that each level of organ stress shortens the window before the patient can no longer tolerate decompression, while each level of inflammation distorts the operative anatomy further. Grade 1 is mild, with no organ dysfunction, managed with antibiotics and fluids for stabilization, then early laparoscopic cholecystectomy within the admission, usually within 7 days, because in that first week, the planes of Colot's triangle still separate, whereas waiting lets the inflammatory rind blur the cystic duct, cystic artery, and common bile duct, and raises the risk of duct injury. Grade 2 is moderate, defined by leukocytosis above 18,000, a palpable mass, symptoms beyond 72 hours, or marked local inflammation like gangrenous or emphysematous change, and antibiotics start immediately, with early cholecystectomy still preferred at high-volume centers. But if dense inflammation has already matured, the alternative is percutaneous drainage now and delayed cholecystectomy in about 6 weeks once the planes return, a decision that weighs anatomic risk against patient stability and is institution-dependent. Grade 3 is severe, with organ dysfunction, and this patient cannot survive an immediate operation. So the sequence is ICU resuscitation plus emergent gallbladder drainage for source control, with cholecystectomy deferred to after recovery and sometimes never done, the catheter or stent becoming definitive. The mortality numbers anchor the urgency. Elective cholecystectomy carries a very low operative mortality, while acute cholecystitis itself runs 5 to 10% across all comers, concentrated in older patients with comorbidity and in suppurative complications, and that gap is why intervening early, before suppuration matures, is the goal. For the poor surgical candidate, the drainage options have changed, because the current therapeutic guideline now prefers endoscopic ultrasound-guided gallbladder drainage with a lumen-opposing metal stent over percutaneous transhepatic drainage, where local expertise allows, and the reason is internalization. The endoscopic approach creates a permanent fistula from the gallbladder into the duodenum or stomach with no external drain to care for, no exit site infection, and no nursing burden, and it produced higher clinical success and fewer reinterventions than percutaneous drainage. An ERCP with a transpapillary cystic duct stent is a third option when neither is available. The contraindications to the endoscopic stent line up with mechanism: perforation, uncontrolled coagulopathy, large volume ascites which displaces the gallbladder from the gut wall and prevents the flanges from opposing, a poor endosonographic window, and critically emphysematous cholecystitis, because that wall is already ischemic and friable and any transmural intervention risks catastrophic perforation, which is the bridge to the last topic. The variants change the host risk, the urgency, and the procedure. Acalculous cholecystitis is a small fraction of cases, but its mortality is dramatically higher, often cited at 30 to 50% in the critically ill, driven by two mechanisms. The first is delayed diagnosis, because the classic patient is intubated, sedated, on TPN, with competing diagnoses already listed, and you can't elicit right upper quadrant tenderness from a sedated patient, so new unexplained sepsis or worsening leukocytosis is sometimes the only signal, and it's nonspecific in the ICU. The second is pathogenesis, because gallbladder ischemia from low-flow states, plus functional cystic duct obstruction from inspissated bile during fasting, drives gangrenous progression faster than calculus disease, so the host is sicker and the disease is faster. Its imaging shows the same wall thickening, pericholecystic fluid, mucosal changes, and distension, but every one of those is nonspecific in the critically ill, because TPN, low albumin, third spacing, and right heart failure reproduce them in a normal gallbladder, which is why a HIDA scan with morphine augmentation becomes the tiebreaker, since morphine constricts the sphincter and forces tracer into a patent cystic duct. So failure to fill the gallbladder under that stress supports obstruction, though false positives from prolonged fasting make it supportive rather than definitive. And the emphysematous cholecystitis is the gas-forming variant, where clostridial or enteric organisms infect an ischemic wall and produce gas in the lumen, wall, or surrounding tissue, with a gas crescent on imaging, typically in a diabetic patient with vascular disease, and rapid progression to gangrene and perforation, with a mortality several-fold higher than typical calculus disease, because the wall is ischemic before infection, and the gas formers accelerate transmural necrosis from within. Management of both variants prioritizes rapid decompression with broad-spectrum antibiotics, covering enteric gram-negatives, anaerobes, and Clostridia in the emphysematous case, with piperacillin tazobactam or carbapenem covering the field, and the drainage decision shifts toward percutaneous cholecystostomy as the first-line option in the unstable patient because it's bedside deployable, doesn't require the gallbladder to oppose the gut wall, and avoids the catastrophic perforation risk of a transmural stent through a friable ischemic wall, which is exactly why the guideline names emphysematous cholecystitis as a laparoscopic or open cholecystectomy is preferred when the patient is stable enough to tolerate it, and gangrene, perforation, or peritonitis force operation regardless of stability because delay itself becomes fatal. While after percutaneous drainage in an acalculous survivor, an interval cholecystectomy is done if the patient becomes a surgical candidate, though in many ICU survivors the catheter is definitive because the ischemic insult is no longer active. So the way of thinking to leave with: the stone phenotype reveals the biochemistry that made it, and the biochemistry is the risk factor list from the mechanism side, with cholesterol stones from supersaturation, dysmotility, or nucleation, black pigment stones from excess unconjugated bilirubin, and brown pigment stones forming new in ducts under stasis plus bacterial deconjugation, which is why times since cholecystectomy splits retain stones from new ones. Asymptomatic stones are observed because the math favors it, unless a cancer or surgical emergency configuration shifts the calculus, and once true biliary colic appears, cholecystectomy is the answer. When persistent obstruction converts colic into cholecystitis, the Tokyo grade dictates how aggressively to operate, from early laparoscopic surgery in mild disease, to early surgery at experienced centers, or delayed surgery after drainage in moderate disease, to drainage and ICU support first in severe disease, with the endoscopic stent now preferred in the poor surgical candidate with stable anatomy, and the friable ischemic wall of the acalculous and emphysematous variants pushing drainage back toward the percutaneous route. The next episode picks up the less common gallbladder presentations organized around chronic remodeling and rare mechanisms, Merizzi syndrome and the staging that governs its reconstruction, porcelain gallbladder and the calcification pattern that decides whether you operate, gallstone ileus and Bouveret syndrome with the classic radiographic triad and the level of impaction logic, gallbladder polyps and adenocarcinoma with their size thresholds, and the functional gallbladder disorder where overutilization is the dominant risk. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 1 of 4 of chapter 27, and I'll see you in the next one.